Thank you. So this is my disclosure. Before I get started, I'd like to make this distinction between deep and superficial. There's always a controversy, especially if somebody comes in with a venous ulcer, what do we treat first? I think this is a very different type of patient. If you have deep venous insufficiency associated with iliac vein compression, this patient, if they're symptomatic enough that they need treatment, you need to have swelling on examination. They need to have severe edema. They may have venous claudication. This is very different from somebody who solely has superficial venous reflux. They have superficial symptoms such as varicose veins, venous ulcers, skin changes. So they're very different patients. And I go over some papers at the end. How do we treat first and what do we do? The guidelines for the treatment of superficial venous insufficiency is very clear. When you have C2 varicose vein branches of the truncal vein GSP, SSP that are bigger than 5 millimeters and they are symptomatic, this is when you treat. C1 is reserved for more cosmetic therapy. And C3, you do not treat this with superficial venous ablation because you do not treat swelling. It's not going to be beneficial. It's not going to be effective. The patients that you really want to treat are C4 and above. These are the patients that have chronic skin changes, and what you really want to make sure that you prevent is C6, which is the most debilitating part of this disease when you develop venous ulceration. So yeah, you have to be really aggressive when they start developing skin changes. Hopefully nobody's doing this. The very invasive vein stripping, this was done more than 20 years ago. Starting 20 years ago, we started doing endovenous therapy. This is the thermal procedure. This is laser. Laser, you are basically utilizing 1,200 degrees Celsius and you're burning the vein shut after applying local anesthetic. This is radiofrequency ablation that you use microwave energy at 120 degrees and you're basically burning the vein shut. What is the caveat about this procedure is that you can develop nerve damage because you're burning the vein, so you have to be very careful. Rasmussen and all in Europe have compared RFA and laser therapy with vein stripping, and there's still areas in the third world country that are doing foam sclerotherapy, which can be very efficacious if you do it multiple times, not as efficacious as the non-thermal therapy. The difference between RFA and laser is very minimal. They're very efficacious in terms of pain after the procedure. Pretty similar, but RFA does a little bit better. Stripping is a very efficacious procedure, but the pain score is much higher. And foam sclerotherapy, the efficacy drops to about 80% closure rate at 1 year. In the past 10 years, there was an emergence of non-thermal and utilizing no energy. And this is the MOCA therapy. This is a therapy where you are damaging the intima of the vein by this catheter. It rotates at 3,600 RPM, and then you make the vein small. Now you make it into a simple sclerotherapy, inject sclerotherapy, and then you close the vein. This paper by Elias shows that the closure rate at 1 year is over 96%. And when you compare to RFA, this paper shows that they have less pain post-operatively, earlier return to work. The other non-thermal therapy is the glue procedure. I call it the crazy glue for vein. You're basically injecting glue and you're shutting the vein down. If you look at this paper, it's a paper non-inferior to RFA. The only problem with this procedure is not a problem, but you have to be very careful when you're selecting patients. I tend to select patients that are veins that are less than 1 centimeter because on post-market trial, the fovea reaction is pretty high. It's about 15%. So you really can't, you shouldn't be doing on patients that have really big veins, but it's a very simple procedure. It's a catheter-based procedure. Sometimes I do direct injection to inject into perforator. The next widely available therapy that we use is Varithena. Varithena is compound foam sclerotherapy. So basically this foam is mixed out with oxygen and makes more compound. More compound means more surface contact, is more efficacious. The Vantage trial shows that the closure rate at 1 year is 73%. Not as efficacious as the thermal procedure, but it's very well used below the knee to avoid nerve injury on recurrence patients. What do we do in the US? This is a CMS data from a couple of years ago where you can see that half of the procedure now is done non-thermal and the other half of the procedure is RFA or laser. Very, very few of them are done with cladribine because there's no CPT-1 code. There's only a few thousand cases. This is the newest kid in the block. It's robotic echotherapy with high-intensity ultrasound beam, creating a thermal energy leading to vein shrinkage and sealing. This is a non-sterile single operator, no catheter, no puncture procedure. They're studying study is being done in the US. It's almost done. They were going to publish their data at the end of this year, and there will be an FDA approval hopefully by next year on market on 2026. Let's switch a little bit of gear and talk about iliac compression Maytherner syndrome. This is when the left common iliac vein is compressed by the right common iliac artery, and you can create this fibrotic or scarring of that area. In severe cases on this venogram, you can see the pancaking, the lumbar collaterals, the contrast stagnation. What are the society guidelines for this? The society guidelines for the treatment of superficial venous disease is very clear, as I told you, but the guidelines for the treatment of iliac compression is sort of a gray area. There is a high prevalence of asymptomatic populations, so multiple people have shown that if you scan everybody, about 25% of this patient, you may find Maytherner. That doesn't mean everybody will have symptoms. Only about 25% of this will have symptoms. So you should not preventively treat this patient because most of them will not develop symptoms. There's also a gray area about what diagnosis to do. This group in Sternberg have shown that ultrasound can be very beneficial in diagnosing this patient. However, those are very complicated ultrasound, and you need staff that are really well trained to do that. In my practice, if we find patient with severe symptoms, I always get a CT venogram or an MR venogram, especially because if you're going to put a permanent metal in somebody, I think you really have to diagnose it. And of course, we use IVUS on everybody for sizing purposes and then landing. So I think it's much more clear. Patient with thrombotic or patient we have DVT, they're much more symptomatic. So when we do this procedure, the pain scores are much better post-procedure. But with iliac vein compression, Maytherner or the nibble, the non-thrombotic, is a little bit unclear. So who do we treat? Asymptomatic, mild, severe is a little bit unclear. And of course, we want high patency, but the resolution of symptoms is very important when we treat this patient. Previously, for the past 20 years, the Wilson from Boston Scientific was a primary stenting for iliofemoral obstruction. However, the problem with the stent is that they can shorten upon deployment, and the ends are very weak. So now we have FDA-approved stents that are 9-0 flexible, fracture-resistant, and precise landing. So I think there's no question that if you have a patient that needs this, we will deploy one of these stents that are approved, which is the Avery, the Beachy is out of the market, the Silvermina, and the Vinovo. And they have data after 36 months with fairly good pacing rate in the 90%. Avery stent is the only stent that I actually looked at. The pain score improvement, and of course the pain score improvement was much better if you treat somebody that has DVT or post-thrombotic syndrome. Again, the nibble, there was a decrease, but not as much as the other group. This is, I think, what I really like to focus on when I treat my patient with superficial or iliac vein obstruction, because at the end of the day, this is the most debilitating patients or disease. And the main thing that you have to think about is venous hypertension that is causing venous ulceration. So how do we treat it? There's a level 1 evidence trial. This is the ESCAR study in 2004 that if you do a superficial venous treatment, there's improvement in the ulcer healing. This is the latest trial. This is another level 1 evidence trial published in the New England Journal of Medicine that if you treat early within 2 weeks, you have improve and faster ulcer healing. So this is clear level 1 evidence that if somebody has ulceration, you have to treat their superficial venous reflux. How about venous stenting? There's a lot of multiple trials that shows that if you do venous stenting, there's improved healing. This is another paper that shows that if you do combined superficial and venous stenting, there's improved healing of the venous ulceration. So Peter, Lawrence, and all looked at 800 patients with 12 other institutions, and their conclusion is that truncal venous reflux treatment as well as venous stenting can contribute to the healing of the venous ulcer. However, they concluded that treating patients with superficial venous reflux first is more beneficial because it's much easier. You do it in the office. You don't need CT or venogram. You don't need to go to an ambulatory center. You don't need an angiogram. So they proceed with superficial venous treatment first, and if they don't heal, they search if they have iliac obstruction or causing venous hypertension. So in conclusion, the guidelines for the treatment of superficial venous reflux is very clear. We do need more data on iliac compression treatment. It's a gray area that we don't know how much of a conservative treatment we need to do, what imaging modality we have to do it prior to this treatment, and we need better guidelines for the treatment of nipple. Thank you.